the Federal Emergency Management Agency, FEMA. And he's going to tell us how FEMA is working to support the efforts of partners at the state, tribal, local, and territorial levels to vaccinate people in a safe and equitable manner. David?
Rich, thanks so much. And we're so grateful to Rochelle and our incredible teammates at CDC for hosting this and for having us join. Bob Fenton, our acting FEMA administrator, sends his greetings. He's actually in New York today, where along with our state and local partners, he'll open 2 community vaccination centers up later this week. More on that in a minute. Along with responding to urgent disasters in the South and Southeast, most notably Texas over the last week, FEMA has no greater priority than ensuring that every American who wants to get vaccinated can do so. The president gave us very, very clear direction. Work alongside CDC and the nation's public health professionals to marshal the resources of the federal government to expedite and expand the availability of vaccinations. Through our National Response Coordination Center here in Washington, D.C., and our 10 regional offices around the country, we have been coordinating with CDC, the Department of Defense, and a whole range of federal agencies to bring states, tribes, territories, local governments the resources and support they need to get the vaccination mission accomplished. As Jeff noted at the top, just in the last 34 days, we've been able to provide more than $3.6 billion to 44 states, tribes, and territories across the country. And there's more to come. These dollars are helping with expenses related to leasing facilities and hiring staff, transporting and logistics, a whole range of missions that help make vaccinations something that we can all accomplish quickly, safely, effectively, and equitably. We've deployed thousands of federal personnel in clinical and non-clinical roles across the country, and we have more yet to deploy. We'll continue to be responsive to the requests that we are receiving from the states and tribes and territories. And as you may know, the president took the action of providing 100% federal support to the nation's governors to use their National Guard in all of the COVID-19 response missions. As I noted, Bob is in New York today because we're partnering with a series of states to establish community vaccination center federal pilot sites in heavily populated, socially vulnerable areas, a mission in which you may have heard the Department of Defense is and will continue to be an enormous and vital partner. Last week, the FEMA administrator joined Governor Newsom in California, opening the first 2 of these federal pilot community vaccination centers in Oakland and Los Angeles, again, targeting socially vulnerable communities, each with the capacity to vaccinate 6,000 people a day. And our experience in Oakland and LA reinforced the critical importance of working with community and faith-based organizations to promote equity. In California, we worked side by side with organizations like True Vine Ministries, La Familia, the Asian Pacific Healthcare Venture, the East Oakland Collective, the LA Black Workers, the Koreatown Immigrant Workers Alliance, and the Filipino Workers Center of Southern California to promote awareness and ensure that the communities they serve had an equal opportunity to get vaccinated at these federal pilot sites. Beyond Oakland and LA, the White House has announced plans for 5 additional federal pilot sites in Houston, Dallas-Fort Worth, Brooklyn, and Queens this week, with more sites in Pennsylvania and Florida slated to open next week. These pilot sites are designed to add to states' ongoing vaccination efforts and were identified using CDC's Social Vulnerability Index, census data, as well as input from our state and local partners. Local input, public health principles, equity considerations are informing everything that we do. And in fact, we have convened here at the national level a civil rights advisory group that for the first time in FEMA's history is integrated fully into our National Response Coordination Center and our operations. And we've deployed civil rights advisors to sit alongside FEMA's regional administrators across the country as they support state, local, tribal, and territorial governments with this funding, personnel, equipment, supplies, and the full range of support that we're marshaling from across the federal government. There's no question that we have a hill to climb and that expanding the availability, the speed of vaccination efforts across the country will take all of us working together. FEMA is all in, and we look forward to supporting you in the days ahead. I encourage you to check out fema.gov/coronavirus, where you can learn all about the eligibility for FEMA's assistance programs. And as always, I encourage all of our public health officials and emergency management officials to continue to work together to access the available FEMA resources and those of the broader federal family. Rich, back to you.
Thanks very much, David. Thanks for that presentation and for the work that FEMA is doing around the nation. Let's turn now to Diana Espinosa, who is the acting administrator of the Health Resources and Services Administration. She's going to tell us more about the recent steps being taken to use community health centers as vaccination sites, and also how HRSA is working with partners to reach severely underserved communities, including people experiencing homelessness and people who have difficulty speaking or understanding English. Diana?
Thanks, Rich. It's really an honor to be here today with all of you to discuss this topic, which is just so important to our nation. The Health Resources and Services Administration, or HRSA, is playing a vital role in supporting local community responses to the COVID-19 public health emergency. And we're working hard to ensure that the nation's hardest hit populations receive the COVID-19 vaccine. HRSA is the primary federal agency tasked with combating health disparities and promoting health equity for underserved, geographically isolated, and medically vulnerable populations. From supporting primary care service delivery to financial relief for hospitals and providers on the front line of the pandemic, HRSA's programs reach millions of people at risk and in need. These include families, pregnant women, children, people with HIV, and hard-to-reach populations. HRSA does its work through partnerships, though. We don't do this by ourselves. We award more than 3,000 organizations grants each year, and these include community and faith-based organizations, colleges and universities, state, local, and tribal governments. And HRSA's close ties with community, local, and state organizations enable our agency to be able to respond to urgent public health issues. So since the onset of the COVID-19 pandemic, HRSA has been at the forefront of the federal government response, continuing to ensure the access to essential healthcare services while also standing up COVID-19 testing, therapeutics, and vaccine administration efforts. HRSA's Health Center program has been a critical part of the administration's national strategy to equitably distribute and administer COVID-19 vaccines across the country. HRSA-funded health centers are community-based and patient-directed organizations that deliver quality primary health care to medically underserved communities. Health centers deliver care to the nation's most vulnerable individuals and families, including people experiencing homelessness, agricultural workers, residents of public housing, and the nation's veterans. Nationwide, nearly 1,400 HRSA-funded health centers operate approximately 13,000 sites that provide primary and preventive care to nearly 30 million patients each year, regardless of their ability to pay. Over 91% of health center patients are individuals or families living at or below 200% of the federal poverty guidelines, and nearly 63% are racial and ethnic minorities. HRSA is leveraging these trusted provider-patient relationships at health centers to accelerate COVID-19 testing and vaccinations in disproportionately affected communities. To date, health centers have provided more than 9 million COVID-19 tests, and more than 800,000 health center patients and staff have received the COVID-19 vaccine. 38% of the health center patients who have initiated their COVID-19 immunizations are racial or ethnic minority patients. On February 9th, HRSA and the CDC launched the Health Center COVID-19 vaccine program to directly allocate a limited supply of COVID-19 vaccines to select health centers. ensuring that our nation's medically underserved and vulnerable communities and those disproportionately impacted by COVID-19 are equitably vaccinated against COVID-19. These vaccine allocations are designed to complement, not replace, existing COVID-19 vaccine doses already being distributed by states and territories. In the first phase of the program, 250 HRSA-funded health centers were invited to participate. The health centers invited for this initial phase specialize in caring for populations that are disproportionately affected by COVID-19, including people experiencing homelessness, agricultural workers, residents of public housing, and patients with limited English proficiency. We are also prioritizing health centers that serve a significant population of patients 65 years and older, and we're ensuring that at least one health center from each state or territory was included in this first phase of the program. The full list of the health centers invited to participate is available on the HRSA website. This past weekend, vaccine orders were completed for the first 25 health centers, and vaccines will begin being administered to patients in the coming days. By the week of March 1st, HRSA expects 250 participating health centers spanning every jurisdiction and serving about 13 million patients to be eligible to receive vaccines. Eventually, all HRSA-funded health centers and health center program lookalikes will have the option to access vaccines through the program. HRSA and the CDC are working with state and territorial public health officials, primary care associations, and health centers to address the health center readiness and capacity to participate in the program. We're very excited about this new program, and thank you so much for the opportunity to share information about it. Thanks.
Thanks very much, Diana, and thank you for all that HRSA is doing. Next, we're going to hear from Liz Richter, who is the acting administrator of the Centers for Medicare and Medicaid Services. And she's going to talk about what CMS is doing to make it as easy as possible for providers to give people safe and fair access to the vaccine. Liz?
Thank you, Rich. Good morning, everybody. At CMS, we're focusing our COVID vaccine efforts on 3 areas: affordability, accessibility, and addressing hesitancy about the vaccine. Above all, we want to help smooth the path for providing the available vaccine at no cost to our beneficiaries. And beyond our usual role in billing and payment, we're also working actively with the CDC to increase acceptance of the vaccine by beneficiaries, enrollees, and healthcare workers, especially those in nursing homes. Let me elaborate a little bit on our various efforts. In terms of affordability, our role is helping to ensure that anyone enrolled in Medicare, Medicaid, or the Children's Health Insurance Program, or who's covered by group and individual health insurance can get vaccinated at no cost. Healthcare providers and groups delivering shots can and should be paid for vaccine administration. Even before COVID-19 vaccines were available, we established Medicare provider payment rates for vaccine administration, and we worked with the provider community to establish billing codes. This helped ensure that providers would be able to begin billing Medicare immediately when the COVID vaccine became available. I want to emphasize again that all vaccine recipients, regardless of insurance coverage or immigration status, can get vaccinated at no cost, even if a person has no insurance. In Medicare, this means that no beneficiary should pay a copayment or deductible for a COVID vaccine. And for Medicaid patients, states will pay for vaccine administration without patient copays. Additionally, issuers of most group and individual health insurance plan coverage must cover COVID vaccinations and their administration without cost sharing, both in-network and out-of-network, during the public health emergency. For uninsured patients, thanks to the CARES Act, healthcare providers who administer the vaccine can request claims reimbursement under a HRSA program called COVID-19 Claims Reimbursement to healthcare providers and facilities for testing, treatment, and vaccine administration for the uninsured. To help advance accessibility, we've made it as easy as possible for providers to enroll in our programs to administer the vaccine. We're also doing what we can to make sure billing instructions are clear. And under a simplified billing process called roster billing, providers can easily submit multiple claims for administering COVID-19 vaccines. We've also set up an enrollment hotline that providers can call to enroll in Medicare, and our online toolkit, which can be found on our website at www.cms.gov/COVIDVax, it's an X on the end, has information that Medicare providers need on enrollment, coding, and billing for COVID-19 vaccines. With Medicaid, we're working with states to expand their provider capacity to include pharmacists, technicians, and interns to help administer the COVID-19 vaccine. As we've worked on issues of affordability and accessibility, we're also focused on addressing hesitancy to getting the vaccine. To that end, our Medicare, Medicaid, and Marketplace communication channels are engaging partners and educating their community about vaccine safety and coverage. Through our emails to our constituencies, social media, and partners, we're encouraging social distancing, promoting vaccine safety, and encouraging people to get vaccinated when they can. We're also working with state Medicaid agencies to ensure that individuals who are traditionally harder to reach are not left out or left behind. We'll be ramping up these efforts in the coming months. We also hosted a series of fireside chats on vaccine safety in December and January in partnership with the CDC. These chats were aimed at nursing home staff and designed to address questions and concerns about the vaccine. Additionally, we held several listening sessions with minority health leaders, and we'll continue listening to the needs of minority populations and our most vulnerable communities. Finally, at this year's virtual CMS Quality Conference next week on March 2nd and 3rd, we'll be convening a COVID-19 vaccine panel discussion addressing facts, concerns, and myths about the COVID-19 vaccines. A diverse panel will provide perspectives from the medical community, researchers, and frontline staff. Going forward, CMS will continue to address all issues related to successful vaccine administration, including those of affordability, accessibility, and hesitancy, as we work within our agency, within the department, with other federal partners to expand and advance COVID vaccine vaccination throughout the nation. Thank you, and back to you, Rich.
Thanks very much, Liz, and thanks to everybody who's working at CMS for what they're doing in terms of the response. We're now going to hear from our final panelist, Josh Peck. He is the Deputy Assistant Secretary for Public Engagement at the Department of Health and Human Services, and he's going to talk about the need for and the importance of a strong public health, a strong public education campaign about vaccination. Josh?
Thank you, Rich and Rochelle, and to my colleagues at the CDC for hosting this important forum. Public education is a critical component of America's COVID response because it's our collective behavior that impacts the way the virus does or does not spread. Public education is a shared effort. The Department of Health and Human Services and its agencies, state and local governments, public health officials, doctors and nurses, employers, community-based organizations, and even individuals have been working to teach people how to protect themselves, their families, their coworkers, customers, and patients. We're here today because we're entering a new phase in this effort. Vaccines offer a new way to protect our communities and our families, but once again, they depend on our collective behavior to be effective. The latest surveys of the American public show there is a spectrum of views towards vaccination, from people who have no intention to get vaccinated, to those with questions, to those who want it as soon as possible. A successful public education effort will need to speak to people across the spectrum. I believe the 3 C's of vaccine hesitancy, complacency, competence, and convenience, will be an important guide for our work. Complacency is the perception of risk that the coronavirus poses. If risk seems low, vaccination and protective behaviors like masking may not seem necessary. Confidence is the trust in the effectiveness and safety of the vaccines and the system that delivers them. We must give people answers to the reasonable questions they have about the vaccines. Convenience is how easy it is to get vaccinated. Are vaccines available, affordable, accessible? Convenience is a problem when you can't get an appointment, you need to drive an hour, you speak another language, or you can't get time off work. Even someone who really wants a vaccine may not get one if the process isn't easy. And for some, even the smallest obstacles will seem like mountains. We will collectively need to address all 3 C's to combat vaccine hesitancy. I also want to talk about 2 values that will be central to our efforts. First, our work will be science-led. The guidance and information we provide to the American public will be driven by science. We'll aim to make sure that science is as creative and accessible as possible, but the advice of public health experts will guide our work. For example, over the last month, we've been working to embed experts from the CDC directly into the decision-making and day-to-day operations of our public education campaign. Second, our work will place equity at its core. Vaccine hesitancy is highest in communities of color and in low-income communities, the very communities that have been hit hardest by the coronavirus. Creating relevant and in-language public education efforts that target these communities and the specific challenges they face will be a priority. This administration is committed to a robust federal public education effort that helps Americans protect themselves from the virus, builds confidence in the vaccines, and makes the process easier. In the weeks to come, we'll start rolling out these new efforts, but we cannot do it alone. This is a historic undertaking, and it will require a society-wide response for us to succeed. Thank you, Richard.
Thanks very much, Josh. And thanks to all of you for your initial insights. We have a little time now for some discussion, and I'll ask some questions, and then I'll throw in one from a question from someone who's joined us today who submitted one at registration. So Rochelle, the first question I'll throw to you. You're now 1 month into the job at CDC. I imagine feels like it's been a long month. You come straight out of clinical experience. What initial reflections do you have on how we can collectively help drive vaccine uptake and implementation, and how can CDC best support the activities across the nation?
Thanks, Rich. I think Josh spoke a bit about this, but I think we have so much work to do to really understand and meet people where they are. We can do some of this work at the CDC, but we really do need our partners in states, tribes, territories, localities to really tell us about their communities. We need to engage at all levels. We need to engage the community. We need to engage the population. We need to engage the individuals. We need to engage in social networks. And we really need to understand at the core, what is it that's making people lack confidence in the vaccine if they do in fact lack that confidence. So is it that they don't perceive that they are at risk? Is it that they feel like the science moved too fast? Is it that they believe that it's not convenient for them, that they don't have access to it? Or is it that they're worried about their side effects, the safety profile? And so we need to understand where they are in that sort of hesitancy, and then inform them with our local partners, with toolkits, with support, with informed knowledge, and to do so with community-based organizations, faith-based organizations, really using all of the networking at our disposal to make sure we can meet people where they are. And then we need to have not just one opportunity for vaccination, but opportunities for people to say, maybe not today, but next week I might be ready.
Thanks, Rochelle. I think that last point is critically important, that what someone decides today may not be where they are tomorrow or next week. And respecting that it's a very personal decision, and different people will reach conclusions on different time frames. This next question is for both David and Diana, and it's, how can community-based organizations and other partners help FEMA and HRSA ensure that the most vulnerable Americans have an equal chance to receive vaccinations? And how are you leveraging community-based data to help with distribution and administration of the vaccine?
Well, for FEMA, Rich, we have learned just very, very acutely from the first 2 sites that we have opened in partnership with California, the critical importance and the value that community-based organizations have played in allowing us to reach socially vulnerable communities, or communities that may not be reached through broad-based communications and messaging strategies. So I think what we are doing now is taking those lessons and reinforcing them across all 10 of our regions, not only for the federal pilot sites that I mentioned we are opening in a series of states in the weeks ahead, but also as our regional administrators support state emergency managers, state health officers, and others with funding or supplies, equipment. It gives us an opportunity to have conversations with them and promote the connections with these community and faith-based organizations that have social capital that we all need to tap into in order to reach some hard to reach communities. And I think one of the other things I would point out and draw folks' attention to is that FEMA funding can be used to communicate about vaccination efforts, including in creative ways. And so I really would encourage the public health officials to work with local and state emergency management officials where resources are a limiting factor to try and help get some funding from FEMA to support those efforts.
I would add that, from the HRSA perspective, we just have these wonderful relationships that are already built with these communities through our various programs. We've made investments in rural testing and learned a lot from that. We have home visiting and programs that are focused on young families. And so leveraging those existing relationships to have the discussion that we've been talking about, have that discussion about getting vaccinated and when the right time is. I think the data piece is also really important. And we've been doing reporting and kind of tracking to see where folks are and what areas might need more resources. But we've also been collecting kind of more informal data by having conversations and hearing stories about where the challenges are so that we can help from the federal level coordinate and get the resources or perhaps come up with strategies to address some of the challenges that folks are facing. So I think that's an important part to recognize that the data is not just the quantitative, but the qualitative and the experiential, so that we can all kind of continuously improve this process, because it is a massive undertaking.
Thanks, Diana. Josh, here's a question for you. Let's talk a little bit more about education campaigns. When you're thinking about creating and launching education campaigns, what sort of data do you rely on to craft those, and how do you get that data?
So, data is going to play a critical role in our decision making. Building vaccine confidence is going to require different approaches for different communities. We know that there isn't a silver bullet or a one-size-fits-all solution. And this is where data can be really helpful. Surveys will help us assess the attitudes and knowledge of vaccines and the coronavirus more broadly, but specifically among subpopulations. Right now, the census is currently asking Americans questions about vaccine competence through the Household Pulse Survey. This is a very powerful data set that will inform work across government. The Kaiser Family Foundation and others are also running surveys looking into vaccine hesitancy and will be tracking vaccine confidence over time. We're going to use all the available survey data out there to target subpopulations with higher vaccine hesitancy, but also to develop the answers to the unique questions or challenges that each subpopulation might face.
Thanks, Josh. Liz, this question comes to you, and I know that CMS has been hosting fireside chats with a number of different groups representing frontline workers. So nursing home and long-term care, health providers, certified nursing assistants. What have you been learning from these fireside chats, and how's that information going to be used?
So we've been working closely with nursing homes since the beginning of the pandemic, and we're continuing to partner with CDC and the nursing home industry to address concerns and myths about COVID vaccine. I would sort of point to two main things we've been learning. The first is the importance of peers as influencers. People trust their peers. For example, in some of those fireside chats that we've both mentioned now, certified nurse assistants have answered questions and explained why they took the vaccine to other certified nurse assistants. And that's really helped them get comfortable with the vaccine in a way that maybe hearing from us wouldn't have, because they're hearing from people who actually experience the same thing that they do. And the other thing I think a couple of us have pointed out, with time, people can change their minds. As more information became available, some people who initially declined the vaccine are now taking it. And that's why we're continuing our partnership efforts to help advance a vaccine update and address hesitancy within communities. It's not just a one-time intervention.
Thanks, Liz. Rochelle, here's a question for you from one of our registrants. Heidi from Wisconsin asks, how can we overcome the politicization of COVID-19 vaccination that's been taking place?
Thank you for the question. I think now is a time for unity. We've hit 500,000 deaths in this country. We know that this disease has no borders. It crosses demographics, it crosses red, blue, it crosses all people of this country and around the world. We also know that we can be very much influenced by what happens in other areas. The more the virus is replicating, the more these variants will be a concern. So now really is the time to unify. We do need quite a bit of vaccination around this country if we're going to reach this golden herd immunity that people are talking about. So now is the time to mobilize your neighbors, your community, your social networks, to understand that this is we all want the same thing. We all want health for this nation. Thanks
so much. So in the last few minutes that we have left, I want to do a lightning round, a round robin. It has to do with the future, and I know in a rapidly changing situation, it's so hard to predict what's going to be coming. But for each of you, if you could imagine, it's now 6 months into the future, 6 months ahead. What will you be most proud of as it relates to the COVID-19 vaccination effort in America? And let's see, Josh, do you want to kick it off?
You bet. I think, the first thing I'd say is it really is both a journey and a destination. Every single vaccination over the next 6 months is a victory and will help slow the spread of the coronavirus. I'll be proud of our work if we can run a public education effort that reaches every American, but especially those that have been hardest hit, and helps address the unique questions or challenges that they face.
Thanks. Liz, what will you be proud of?
If the general public has numerous options for where to get a vaccine and providers are paid efficiently for administering it, if everyone, no matter where they live and whether they have insurance, has easy access to a free vaccine. And I think most of all, in some senses, if you live in a nursing home, that you can have visitors and enjoy social activities again because enough people have been vaccinated.
Diana?
I guess I would probably just add, in addition to just having vaccines available, with equity, with an equitable system, I think, being able to see that our healthcare system has really kind of gotten back to where it should be, and people have gotten those preventive services and those immunizations that they may have delayed, because I think we can't forget, that this is also impacting people's health in other ways.
David?
I'm optimistic we will be able to be proud of the way that folks from DOD and from FEMA and from other professions came in to support, back up, and follow the nation's public health leaders in getting this vaccination mission accomplished as a team and equitably. And that, for me, the other thing that I think we're going to be able to do on the other side of this is take the approach that we had to promoting and driving equity in this mission into our broader disaster response and recovery mission, which I think will be a really important knock-on benefit.
Thank you. And Rochelle?
Much of what's been said. I think 6 months from now, we'll have enough vaccines for 300 million people, and I would love to see 300 million people vaccinated. I would love to see that when we did so, every step of the way, we were laser focused on the equity lens, and we made sure that, that the people who were hardest hit by this pandemic were vaccinated at a rate that was comparable to how they were hit, if not overcompensated. And then really at the end, in the fall, that we leverage the lessons that we learned in doing so and reaching those hardest hit communities and leverage them to make sure we did so in all aspects of health.
Well, from your words, may it all be so. I want to thank all of you for being here and sharing your remarks on this all of government effort. I want to thank the audience for being here today and encourage you all to stay with us over the next few days for what I think will be some really important and informative sessions. I am absolutely thrilled to hear how central equity is to the work across government, because without that, the color of your skin, how much money you earn, will have a disproportionate impact on how you weather this pandemic. And may we all look back after 6 months and say that wasn't the case, that vaccines were available to everyone in America, in particular to those who were being hit the hardest. So thank you. And it is time for our next session. So please stand by and we will transition over.
Most people in the United States are planning to get a COVID-19 vaccine, but some may want more information before choosing to get vaccinated. Be prepared to answer questions about how the vaccines are developed and authorized. And remember to emphasize that they are safe and effective. People may have previous experiences that affect their trust and confidence in the health system.
As a running back, I took a lot of hits on the field, but I didn't want to get hit by COVID, so I got vaccinated. Don't take the hit. Get vaccinated.
I'm getting the vaccine to continue my culture
so that I could dance another day.
so I don't have to lose another brother. Sleeves up, Nola.
Sleeves up, Nola.
Sleeves up, Nola.
My name is Dr. Leandris LaBird, and I am the Chief Health Equity Officer for CDC's COVID-19 response. Today, we have a rich tapestry of people who have come together for the sole purpose of getting COVID-19 vaccines into people's arms quickly, safely, and equitably. You join us from every state, Washington, D.C., 7 U.S. territories and freely associated states, and over 125 tribal nations or organizations. We thank you for joining us and thank all of you for your tireless work in the past year fighting this pandemic. We also want to thank you in advance for your participation in the work that's still to come. While we have a growing supply of safe and effective COVID-19 vaccines, and we see progress being made every day in getting people vaccinated, we still have a long way to go. Building trust and confidence in COVID-19 vaccines is essential, especially when it comes to vaccinating people equitably. We have more work to do to successfully reach many of the people who have been disproportionately impacted by COVID-19. Over the course of this forum, 109 experts from across 31 states and tribes will share their stories of how they have been contributing to this historic vaccination effort. They will highlight their challenges and lessons learned. This work has not been easy, but we are confident that their stories can provide everyone listening with practical ideas on what you can do in your organization to bring COVID-19 vaccination to all communities. I cannot think of a more important aspect of ending this pandemic than building trust in the vaccine, but also in the providers who will be administering the vaccine, and in the national, state, and local leaders who are working every day with communities to foster confidence in all aspects of our efforts to protect people, particularly those who are at increased risk for severe illness. As I interact with family, friends, and with members of my own community, everyone is talking about COVID-19 vaccines, and they're grappling with making a decision about whether to get it or to wait. Invariably, I am asked what I think about getting the vaccine, or to validate or clarify something people have heard on TV or in their daily interactions with friends, with family members, as well as with other community members. What I tell them when they ask is that based on the available science, I think getting vaccinated is a good idea, and that I myself plan to be vaccinated as soon as possible. These experiences have underscored to me that there are so many questions and a real hunger for accurate information in communities across the country. This forum comes at the perfect time as we organize to meet the needs of communities across the country for reliable information they can trust and act upon. I am so excited to be part of the National Forum on COVID-19 Vaccine and to welcome you to our first plenary session focused on the importance of trust and vaccine confidence. Today, we begin our plenary by hearing from some national experts on the importance of addressing systemic health and social inequities, the safety and effectiveness of COVID-19 vaccines, and the work we need to do to build confidence in all communities. Our first speaker is Dr. Cameron Webb, who is the Senior Policy Advisor for Equity for the White House COVID-19 response team. Dr. Webb, thank you for joining us today.
Thank you so much for having me, and it's exciting to be here, Dr. LaBerge, to join into this really important conversation. And I'll start off by saying this. Long before 33 days ago, when I joined this Biden-Harris administration as a senior policy advisor for equity on the COVID response team, I was a practicing physician. Work as an internal medicine doctor, a hospitalist at the University of Virginia in Central Virginia. It's a community that I'm passionate about, that I love and I care deeply about. It's a community that's kind of nestled in the Blue Ridge Mountains. It's known for its major university and even its kind of budding industry around wineries and breweries. It's also known for a really terrible moment in 2017, the Unite the Right rally, which really highlighted challenges with race and dynamics here in our nation. But just the same, this is a community that I'm incredibly invested in and that I've continued to be over the years. About a year ago, we were planning as a healthcare system for this coronavirus pandemic. And one of the things that stood out to me was that we knew it was going to disproportionately impact different communities. Here in Charlottesville, we're pretty attuned to some of the challenges with regard to race and ethnicity, the challenges with regard to structural inequality and systemic racism, and how they coalesce to create difficulties, whether it's in education or access to food systems, whether it's in transportation dynamics, and yes, even in our healthcare systems. Shortly after COVID arrived here in Central Virginia and in the United States more broadly, we realized those potential inequities were cropping up. We knew that this was going to be a challenge, and yet here it was. One of the first things that folks started to do is step up in communities all over this country. They made masks for each other. We made sure that we were pushing for people to have access to testing. We pushed for a stronger data infrastructure nationally to make sure that we knew who was getting access to testing and who could find out whether or not they had COVID. But early on, it was pretty clear. COVID was impacting different communities differently. There were groups that were at greater risk, whether it was older adults or individuals who live in congregate living settings, folks who have a burden of chronic disease. When I walked into the hospital and I work on the coronavirus unit, what I saw were people who were disproportionately Black and brown, people who were disproportionately essential workers, and people who disproportionately were not given the opportunities and the access to our healthcare system that they so sorely need. Now, fast forward a year later, and we hit a grim milestone. 500,000 individuals in this country who died from coronavirus. But here's the thing, that impact has been disproportionate. We've seen that Black individuals here in the United States are 1.9 times more likely to die from COVID. For Latino individuals, 2.3 times more likely. Native Americans and Alaskan Natives, 2.4 times more likely. We've continued to see anti-Asian sentiment that is really challenging the dynamics that we have in our communities. No matter what community you're talking about, COVID is hitting different communities differently. That disproportionate impact has to be a part of our strategy and has to be a part of our solution. And so as we define equity, the first thing we say is equity has to be the idea that no matter who you are, no matter where you are, you have the opportunity to get and stay healthy with regard to this coronavirus pandemic. And that plays out through your access to healthcare systems, but also your access to therapeutics, and yes, this really critically important vaccine. Now, you heard in the previous session, my colleague Josh Peck talk about the 3 C's of vaccine hesitancy. That's a term that's now become really popularized in kind of communities all over the country. But when you break it down, there's those dynamics of complacency, of convenience, and of confidence. And yes, we know there are challenges with complacency. Some people don't think it's necessary to get the vaccine, but we do know that it causes severe health problems. Yes, there are issues with convenience, and I'll talk about that in a second because we know there aren't enough venues for vaccination everywhere. There's not enough vaccine in communities everywhere. So we have to make sure that we're really ramping up the availability of vaccine for people no matter where they are. But it's in that confidence space that we really find a lot of the unique challenges. We know that there are challenges that folks have with regard to the safety and the efficacy that are rooted in real experiences of folks having access to treatments that weren't necessarily safe or efficacious, being told to take something that didn't really serve them well. We know that one of the confidence issues is confidence in the systems that deliver these vaccines and that include some reliability and competence of the health services and those health professionals. But realistically, here in these United States, that's been a problem for a very long time. Going back to the so-called slave health deficit where there were individuals experimenting on Black bodies, or whether you fast forward to W.E.B. Du Bois and the Philadelphia Negro identifying and articulating those differences in mortality by race and ethnicity in Philadelphia. Or moving forward when Dr. King said of all the forms of inequality, the injustice in healthcare is the most shocking and inhuman. 20 years later, when the Secretary of Health and Human Services issued a report on Black and minority health that showed the dramatic disparities in our healthcare system. And then, 17 years after that, when the Institutes of Medicine issued a report, Unequal Treatment, that really highlighted the role of provider bias. We have more than enough evidence to know that our system has been perpetuating unequal treatment on our populations, not just by race and ethnicity, but also for rural communities that have been so often left behind. So that lack of confidence in the system is a very real thing. And then finally, the lack of confidence in the motivations of policymakers. We've talked about how important it is to get politics out of this process of getting vaccine to folks. People are going to be more confident if they know why it is we want them vaccinated. And the answer is simple. It's to save lives. You know, I want to close by saying this. The Biden-Harris administration, it came in with a different mentality. You've heard already this morning the focus on equity in our vaccine rollout efforts. And that's a very sincere focus. The reason why we're focusing on equity is that you cannot have a successful vaccination campaign in the United States with this coronavirus pandemic without equity. Absent equity, the whole thing falls apart because this virus, it doesn't care your race, color, or creed, your geography. It doesn't care if you live in an urban community or a rural community. It knows that it's going to exploit every crack in our society's fibers. And so we know that equity is our path forward. You know, we have a great leader in Dr. Nunez Smith, who's leading up as the coordinator for equity on the White House COVID response team, but who's also chairing a COVID health equity task force. We have a great team that's focused on getting this work done, getting recommendations, listening to communities all over. And I'll close by saying this week, we're leading a large stakeholder engagement effort, really listening to communities all over the country, getting your insights to know exactly what we can do to answer your questions. Trust is earned. It's not just given blindly. And we know that in communities that have been disproportionately impacted more than anyone else. So we look forward to talking with you this morning through these next 3 days. Glad that you're joining us. And we're hopeful that after this, you can help us spread the word about why people should have a little more trust in this vaccine. Thank you.
Thank you so much, Dr. Webb. We have an opportunity, and we certainly agree, to redouble all of our efforts to eliminate largely preventable health disparities. And so it's my great pleasure to now introduce an amazing leader in vaccine research, Dr. Kizzmekia Corbett. Dr. Corbett is the scientific lead for the coronavirus vaccines and immunopathogenesis team at the National Institutes of Health. Dr. Corbett, thank you for being part of the Vaccine Forum.
Thank you so much for having me. It is an absolute pleasure to have been invited today, and particularly a pleasure to dial back actually what the context of what we're talking about today is, really to the science and the onset of the work that we've done at the National Institutes of Health in the Vaccine Research Center, where I am a research fellow under the direction of Dr. Barney Graham. So I've worked at the NIH, at the NIAID for the last 6 years. And we've been so invested in pandemic preparedness, particularly around coronaviruses, that we studied coronaviruses for the last 6 years. And actually, even prior to me getting to the Vaccine Research Center, to really fundamentally understand how to make a really good vaccine against coronaviruses. Our work specifically with the team that I lead, is in the preclinical development. So that is before the vaccine gets to humans in the clinic, even before it gets to a phase 1 clinical trial. And I know that there are questions all encompassing from all spectrums, whether it be citizens, physicians, et cetera, that have a question about the speed of the COVID-19 vaccine development. And so what I plan to do today for my 5 minutes is to just briefly lay the landscape of how rapid development of a safe and effective COVID-19 mRNA vaccine was made possible, and partly due with our previous work and work of other laboratories and institutions from all over the globe over previous years. So it is notable that vaccine development often takes several years. That is from point A to point Z. That is from the concept of the vaccine design all the way to the point at which it is approved for general human use. One key accomplishment of the current COVID-19 vaccines is that this timeline was shortened, but no integrity was lost. The shortening of this timeline was due to several factors, and I'll just, for brevity here, name a few. The first of which we must acknowledge, is that the vaccine development efforts were coordinated across institutions and companies and otherwise. And then secondly, there was extensive work on MERS coronaviruses and other coronaviruses that really set the stage for our fundamental scientific understanding. For years, we and other researchers have garnered enough knowledge around the coronavirus vaccine development, particularly just zoning in on one protein. So I know that everyone is generally used to thinking about vaccines as inactivated viruses. So those are viruses that can't really infect a person, but can trigger an immune response enough so that if a person comes in contact with the virus later, that they're protected. In this case, we zone in on justices, and for the last several years, studied that protein called the spike protein in such detail that we were able to understand how to make a really good vaccine from it. And secondly, how your body makes an immune response to it. That level of detail that we had really fueled our understanding for the current coronavirus that is causing COVID-19 disease, the virus named SARS-CoV-2. It is interesting because just as we think of ourselves and our families, we have brothers, we have sisters, we have cousins, coronaviruses and other viruses also have families. So the MERS coronavirus that we studied in so much detail over the last several years is, you could think of as a cousin to the current SARS-CoV-2. So the knowledge that we gained from understanding with MERS coronavirus enabled us to really translate that in the onset of this pandemic. Let's talk about the onset of this pandemic. Around the latter parts of 2019, there was a mysterious illness that was a respiratory illness in China. It became aware to us that it was a coronavirus, and around January the 10th, the sequences of that coronavirus was released. Over and over, we have said we went into a phase 1 clinical trial in only 66 days. And I know that seems like a very short time, but it is only because of the years of previous preclinical testing and an established collaboration with the company Moderna that really made that possible. So we knew all that we needed to know about the spike protein, and Moderna had this beautiful platform called the messenger RNA platform, whereby they can deliver therapeutics to the body. Messenger RNA allowed for us to deliver just the coronavirus spike protein to people safely and effectively, and really allow your body to make a really robust and high-level immune response to that protein that in turn prevents your body from getting virus infection and COVID-19 disease later. Aside from the start of the phase 1 clinical trial, there are several key steps that suggested that the vaccine, importantly, we knew, particularly under my direction with the preclinical testing, that the vaccine was safe and created a really good immune response in animals such as mice and monkeys prior to ever testing it in a human. Second of note is that even with the phase 1 clinical trial, it is testing in only a small amount of people to really and firstly assess the safety of the vaccine. Noting that here, as we sit here on February the 22nd, that the first phase 1 clinical trials for the messenger mRNA vaccine started last year in March. And so we are about a year into our understanding of the safety profile of these vaccines. It is that each of the phases of clinical trial builds upon each other. So just as I talked about the phase 1 clinical trial starting as a result of data that we understood in animals, phase 2 clinical trials are informed by the phase 1 and so forth until you get to the phase 3 clinical trial where you get the 90–95% efficacy that we've all heard about. So it is important to note that while it is rapid, this process of vaccine development is systematic and without any sacrifice in any of the steps, whether it be on the preclinical side from which I led or through the phases of the clinical trials that have been moved thereafter. The scientific integrity was at the forefront of all of this vaccine development as it has been for vaccine development previously, albeit more rapid in this case, not only out of necessity and dire need as we are in the middle of a pandemic, but also because of technological advances that have gotten us to this point. And with that, I'll close. Thank you so much to the CDC for extending this invitation. And of course, thank you to the citizens of this country for caring enough about your health and the health of your communities to tune in to this great vaccine forum.
Thank you so much, Dr. Corbett, and thank you for helping all of us to better understand both the development of the vaccine, how it works, and just reassuring us that it's safe as well as effective. So I'd like to move on to our next speaker. Building vaccine confidence, especially in communities that have been disproportionately affected by COVID-19, will require tremendous effort. Building vaccine confidence requires commitment as well as cooperation. And our next guest is someone who is on the front lines and doing this work. Ms. Lisa Sherman is the CEO of the Ad Council and has joined us today to highlight the research-based insights gained during this pandemic, and specifically from the collaboration between the Ad Council and the COVID Collaborators Vaccine Education Initiative. Thank you for joining us, Ms. Sherman.
Thank you, everyone. Thank you for having me. I would like to start by having a big thank you to the CDC for inviting me to be here today to share a little bit about the communications efforts of the Ad Council and our partners as we undertake this effort to combat vaccine hesitancy. I really don't think it's an understatement or an overstatement to say that this is the biggest issue of our lifetime. And because of that, we felt it was critical that we meet this moment with the largest public education effort in our history. You know, the Ad Council's ability to quickly stand up coordinated public education efforts at scale is truly needed now more than ever. And to help us do that, this fall we were honored to join forces with the COVID Collaborative, which is a truly extraordinary organization made up of bipartisan leaders in public health, education, and the business community. The collaborative includes current and former governors, CDC commissioners, FDA commissioners, policy advisors, business leaders, and so many more. Now, our first task was to conduct extensive research to understand the behaviors and the mindsets of consumers who are vaccine hesitant. We conducted in-depth qualitative and quantitative research across all of the relevant target audiences. And the results were very telling. We learned that 30% of the American public is already fully committed to taking the vaccine when it's available to them, and about 15% are fully resistant. We know, of course, as of today, approximately 13% have already been vaccinated. So we see our opportunity as residing in the middle 40% of the population who frankly are taking a wait and see attitude, and they're seeking more information to address their concerns. They're looking for real world evidence that the benefits of vaccination are going to outweigh the perceived risks. Now, when you shift, the mindset shift, if you look across different populations, when we evaluate adoption by demographic, Black and Hispanic populations, who we know, and as you've heard already this morning, have been disproportionately affected by COVID, and understandably have distrust of our medical systems due to systematic healthcare inequities. And so they're more skeptical than their white counterparts. Research has also shown that people's hesitancy across demographics is driven by 4 key areas where information deficits and misinformation exist. These include concerns about safety and side effects, the speed of the clinical development process, distrust in the political and economic motives of the government and corporations, and established and novel conspiracy theories involving vaccines. Through extensive message testing, we have gained rich insight on which types of language and messaging are motivating to this hesitant audience. These learnings include a few things. First, we must acknowledge their concerns. We need to make it clear to Americans that it's okay to have questions about vaccinations. It makes sense, and we can help them get the answers. Secondly, we must highlight those moments of human connection that people are missing the most. Visiting family for the holidays, going out to dinner with close friends, getting kids back to school. These are all broadly relatable and the most missed across all audiences. Third, we must put an emphasis on the vaccine helping to protect themselves and their families. And finally, we must engage with an inviting and respectful tone. We really need to avoid the negative reminders of what a difficult year it's been and resist guilting our audiences, telling them that this is the only right thing to do. So how are we going to do all this? What I'd like to do now is take you through an overview of some of the guiding principles of this initiative. Together, we're going to launch a unified, coordinated communications campaign, which will allow us to have exponentially more impact than any sort of a patchwork response would. Under this very big tent, we will bring together the top creative, tech, and media talent across the public and private sectors, and ensuring that we're working together with a cohesive and impactful messaging platform. We will then extend that messaging to communities across the country at significant scale. Importantly, we will be activating an aggressive ground game as well as an air game that will allow us to go broad and deep. So in addition to our national strategic media placements, along with PR and social media, we will have significant local presence. To accomplish this, we will be partnering with nonprofit, community, and faith-based organizations and building large coalitions across multiple audience segments. And while coordination is key, we know that this is not a one-size-fits-all proposition. We're envisioning multiple distinct campaigns to reach different audiences, especially communities of color, where, as you've just heard and seen, we are seeing higher levels of hesitancy. We also know that we must leverage trusted messengers. The issue of hesitancy is complicated and it's quite nuanced, and trust is at the core. They can be everyone from your local pharmacist, to your doctor, to your minister. These are trusted voices who can help educate people to make empowered decisions for themselves and their families. Messengers can be athletes and artists, and others who would be critical to ensuring that our messaging reaches diverse communities in culturally relevant ways. We'll also continue to coordinate closely with the CDC and HHS and the Biden administration. CDC and HHS will be providing scientific review for all of our content, and we're already finding ways to complement the work that they're doing. This will be the largest, most important national education effort of our time. And I know that by working together to educate and inform the American public, we will soon see better days. So I'd like to thank all of you who have already contributed so much, and I look forward to working with all of you in the days, the weeks, and the months ahead. Thank you.
And thank you, Ms. Sherman, for sharing the landscape of how people are